Thank you. So there are various sources of shoulder pain can coexist, and it's challenging really to be able to reach a diagnosis in some of these patients, especially since asymptomatic pathology, including rotator cuff tearing, is extremely common. All sources of shoulder pain really need to be evaluated in patients with rotator cuff tears and determine, is the cuff truly the source of pain? Even if the cuff is the source of pain after doing your full evaluation, we need to determine if it's still the pain after conservative treatment, because non-operative treatment works very well in many cases. So the goals of this talk are really to review the prevalence of cuff disease, the data supporting non-operative treatment of cuff disease, and then review other common causes of shoulder pain and how to make the diagnosis. Several authors have reported ultrasound and MRI studies on the incidence of atraumatic, asymptomatic, full-thickness rotator cuff tears. Scher found a 34% overall incidence of asymptomatic tears, no full-thickness tears under the age of 40, 30% over the age of 60. Tempelhoff reported a 23% incidence of full-thickness asymptomatic tearing. Problems with the prior data are that these are all asymptomatic tears. More recently, Yamamoto looked at asymptomatic and symptomatic tears, and he found a 20% incidence overall, 25% in patients that were in their 60s, 50% in patients that were in their 80s. Age, history of trauma, dominant hand were all found to be risk factors for tearing. So basically, this data supports that rotator cuff tearing is a normal age-related process that occurs, but as well, there's also trauma that probably plays a significant role, whether it's micro or macro trauma. So if you have a cuff tear, what's the success of non-operative treatment? Multiple historical clinical follow-up studies have shown about a 60 to 70% improvement with non-operative treatment, which remains stable over time. Mattson found significant improvements in simple shoulder test scores out to 3 years, which remain stable. Most recently, Borman performed a prospective study for physical therapy for symptomatic tears, and he found 75% success rate at 3 months, and if success was obtained, it remained stable at 2 years. So really the conclusions from this data are that non-operative treatment works, and it works in a majority of cases. And the question we really need to answer is, can we predict those that actually fail early? And if we can, maybe we can identify those patients that might benefit from surgical repair. Most recently, Dr. Burks asked me to talk about this paper, publication in JBJS this fall, 180 symptomatic atraumatic supraspinatus tears in an older age population. So this is a really homogeneous group, small tears, atraumatic, older population. It was randomized to therapy, acromioplasty, or cuff repair. And what they found was no significant differences in constant scores at 2 years. 89% of these patients also had an MRI that was done at 2 years, and they did find smaller mean tear size in those that actually had repair versus those that did not with either therapy or acromioplasty. And we agreed that this group probably warrants further follow-up with regards to these larger tear sizes. That being said, initial conservative treatment is definitely reasonable for symptomatic small tears that are non-traumatic in an older age population. And this data basically supports what we probably should already be doing and supports that it's reasonable. So what are the conclusions from the cuff data? Is that cuff tearing is common, increases with age, not all cuff tears are symptomatic, and we really need to be looking for other sources of pain, even in the setting of a full thickness rotator cuff tear on an MRI. And finally, even if the cuff tear is symptomatic, there's probably a high chance of clinical improvement with non-operative treatment. So if it's not the rotator cuff, what is really causing the pain? There are several different causes, and we'll go over how to hopefully make the diagnosis. So to start, we got to know what is coming from the cuff. So what pain is coming from the cuff? It's typically lateral anterolateral base shoulder pain radiating to the elbow, not extending distally. Pain and weakness are typically present on resisted cuff testing. Empty can testing, as you can see in the upper right, tests the supraspinatus. External rotation tests the infraspinatus. With severe injuries of the subscap, infraspinatus, teres minor, you can see positive abdominal compression test, ER lag signs, or horn blowers. Positive Hawkins and near impingement tests, as you can see in the upper right, are consistent with a subacromial-related source of pain. Imaging, probably not that helpful. It may show edema in cases of acute traumatic injuries, but otherwise, to differentiate between symptomatic and asymptomatic cuff tears, it doesn't really give you much information. What is very helpful is pain relief with a subacromial lidocaine injection, as originally described by Dr. Neer many years ago. And you can use this to help identify the cuff as the source of pain. Biceps tendon can be a significant source of pain. It's a spectrum from tendonitis to partial thickness tearing to complete ruptures with or without instability. The key is every patient with a cuff tear or tendonitis needs to be evaluated for the biceps, as it's often a very significant source of problems. How do you make the diagnosis? Clinical presentation is typically anterior shoulder pain, radiates down to the muscle belly. Differential includes AC arthritis, glenohumeral arthritis, subscap tears. On exam, multiple tests have been described over the years, but nothing's really been shown to be sensitive or specific. Dr. Kibler described the uppercut test, which you can see in the upper right, and he found increased or improved sensitivity, specificity with this test. That being said, what do I use in the clinic? I use basically a history of groove pain, tenderness over the biceps tendon, as well as Dr. Kibler's test. On imaging, it can be useful to confirm other pathology like a cuff tear, complete rupture of the biceps, or subluxation out of the groove, as can be seen on the right, but it's really not sensitive for inflammation or partial ruptures. And finally, glenohumeral injections or sheath injections can be very helpful. I usually do these under ultrasound or imaging, as it can significantly improve the accuracy. Cervical spine can be a significant source of pain. It can be radicular or related to the facets. Typically, the pain radiates past the elbow and does not stop at the elbow like cuff pain. Posterior pain is very common, radiating to the superior medial angle, and this is usually associated or secondary to facet arthritis. The type of pain is very different. You see a patient with radicular pain, they don't want to move sitting in front of you in their clinic, and they're very unhappy. It's very different than a patient with cuff pain. It's constant. It doesn't correlate with shoulder activity, unlike patients with rotator cuff symptoms. Actually, the pain is improved with overhead elevation, unlike most shoulder pathology with reduction of tension on the nerve roots. Being able to make the diagnosis, you can see motor and sensory changes distally, positive spurlings, and what do I use, and I think it's very helpful, is test them for weakness in forearm supination, and that can be very predictive of a C5 root palsy, and usually I'll do this, and if someone has a true cervical spine source of pain, they'll have a gross difference between one side versus the other. Glenohumeral arthritis, chondral injuries, can be very common and cause pain. They can be global with osteoarthritis or focal secondary to isolated chondral lesions. Night pain's common, but it's positional, so people can get to sleep, unlike people with rotator cuff tears. Mechanical symptoms are common. Location is typically posterior first and then global, unlike the predominant lateral-based shoulder pain with cuff disease. On exam, the range of motion is initially preserved, and then you lose external rotation, then global loss. The key on diagnosis for me is that the rotator cuff is usually strong and not painful in these patients with chondral injuries. Imaging can be a little tricky. X-rays often early on are normal, and you really don't want to get fooled. In the upper right-hand pictures, you can see a patient with very mild disease, or basically normal shoulder, and then you put a scope in and you see they have no cartilage on their humeral head. And so you have to be aware of this. MRI can also be used to identify cartilage injuries, but the key is don't get blinded by the cuff tear. You don't want to miss these injuries. It's very common to say there's a very large supraspinatus or infraspinatus tear, but then you put the scope in again and there's a very large chondral injury. You can use MRI to see these injuries on the humeral head or the glenoid. The labrum can be a potential source of pain, specifically superior labral tears. And my only plea is that most of these or many of these are traumatic and degenerative, so don't overtreat them. If there are symptomatic, it's typically pains posterior or anterior over the biceps. Many of the physical exam symptoms or signs are similar to bicipital signs with tenderness if it's anterior-related pain, or positive O'Brien's. The combination of O'Brien's and the modified dynamic labral shear test, as described by Dr. Kibler, has been shown to have the highest sensitivity and specificity to identify a true superior labral tear that's symptomatic. Again, injections can be helpful. Suprascapular neuropathy is a common source, or can be a common source, depending on your practice, if you happen to practice in Boston. It typically occurs with compression at the suprascapular notch or spinoglenoid notch. I consider this the great mimicker of the shoulder. Granted, it's not syphilis, but the bottom line is I think it is the great mimicker. And typically people have vague, deep shoulder pain that is difficult to diagnose. What's the classic presentation? Young patient, weakness, atrophy, vague, deep pain that has no or minimal cuff pain with testing. The thing is, many patients don't have any weakness, don't have any atrophy, they just have pain. Similarly, on imaging, you can see a cyst or an atrophy, but most oftentimes it's normal. EMG studies can be helpful if they're positive, but oftentimes they're normal. So what do I use? I confirm a diagnosis if I think this is the problem using a local anesthetic injection done under ultrasound at the suprascapular notch. AC joint can also be a significant problem due to osteolysis or arthritis. Pain is typically superior and anterior. Again, many of these AC joints that are arthritic are asymptomatic, so you don't want to overtreat them. MRI can be very helpful, showing edema, the clavicle, acromion, or both, if there's symptoms. So that's something to look at on your imaging when you have an MRI for a cuff tear. Tenderness, cross-body adduction, O'Brien sign, all can be helpful in making the diagnosis. And again, injections are very helpful, although long-term pain relief with an injection for AC arthritis has shown to not be that successful. There are zebras out there, so don't, you go through your common list, there are things that are uncommon. AVN, tumor, quadrilateral space syndromes that you can see with atrophy of the teres minor. Anterolabral tears can actually cause pain without instability, as described by Pascal Boileau. Parsonage-Turner syndrome. The key is that there are many sources of pain. Think of the horses first, and then think of the zebras. So in conclusion, cuff tearing is very common. Many tears are asymptomatic. Don't just presume that they're the source of pain if you see them on an MRI. And many, if they are symptomatic, they can be treated conservatively. If you're looking for other sources, utilize demographics, history, exam, imaging, and I use a lot of selective injections to be able to differentiate these other sources. Consider common pathology first, and then the more unusual. And finally, really, the success of treatment is dependent on identifying all the potential sources of alternative pain, consider them, treat them either in isolation or when you're actually treating your cuff tear. Thank you.